Thank you very much. Sorry, it's me again. We've talked a lot about self-management, and Renata herself admitted to not always approaching it in the way she does today. And the fact that I'm standing up here, sorry, is this echoing a lot? No, okay, just me. The fact that I'm standing up here today as an advocate for self-management is something that I would have probably laughed at if you told me 5 years ago. Because before I was diagnosed with my long-term health conditions, I was a medical student. And for me, self-management and the concept of an expert patient was pretty alien to me. I'd spent my evenings in an ivory tower trying to learn unpronounceable drug names. And yet Jay Bloggs walked into clinic the next morning with a printout from Wikipedia saying, this is my condition, this is my diagnosis, this is what I want you to do about it. And since making the transition from medical student to patient, I've actually realised that that's not necessarily about what being an expert patient is. But it's not just myths that I've had. One of my neurological consultants, in response to finding out that I'd done the expert patient programme, which was a real turning point for me, said, oh, that's great, you don't need me anymore. And I'm not quite sure whether he was joking or not. I still need him an awful lot, but I just need him in a slightly different way. So self-management isn't necessarily a get-out clause for clinicians in terms of getting to wash their hands of patients and not having to do anything. It's just a way of changing that relationship. I've been very lucky to live in Dorset, where we've just commissioned a really exciting new self-management service. And working with lots of patients in Dorset, I've started to realise some of the myths that they have about self-management as well. So somebody thought that having been on an expert patient programme course or some sort of self-management programme, that they would then no longer be allowed to access their GP because they should be completely and utterly independent. And that's not true. Yes, some of the statistics show that you use healthcare professionals less, but actually the bulk of it is the fact that that relationship changes. And the other myth that I heard, which certainly would put me off self-management, was that you had to go back to school to study biology, to learn exactly what hemoglobin was, to work out the difference between your atrium and your ventricles. And that's really not what self-management's about. It's not necessarily understanding the minutiae of the medicine behind your condition. And it's not really a discrete event either. So for me, self-management is very much a complete mindset and a complete way of life that extends just beyond my nervous system, which is where all my conditions stem from. Actually, it affects my social circumstances and my psychological condition as well. And so for me, self-management is about pacing myself, and it's about doing my physio exercises and taking the right medication at the right time, and it's about going to my GP and my consultant appointments with the right list of prepared questions and priorities. But actually it's about how we live on a day-to-day basis with the depression, the anxiety and the stress that all of that brings. And so when I was a medical student, I learned about something called the biopsychosocial model of disease. And I thought that it wasn't really something that was worth learning about. I just thought, right, people with long-term health conditions, if you just give them the right medications and they go to the right appointments, that's all that matters. And it's not, it's about that quality of life in between. So it's how I manage the stress and the depression and how I manage the impact it's had on me socially in terms of career-wise, financially, and socially in terms of how it's changed the dynamics within my family. So suddenly the biopsychosocial model, which was something that I'd kind of dismissed in my first year at medical school, was something which had suddenly come to life for me. It was no longer a theory that was sort of resided to the dusty tomes on the shelf. Actually, yes, my nervous system isn't working as it should do, but actually that's not the only thing that's happening. There's the psychological and the social aspects as well. And suddenly by bringing this model to life, it reframes the way I can manage my condition. So before, I thought about it in a medical model. So it's just my nervous system. I've just got to make sure I have the right MRI scans, see the right neurosurgeons, and that's fine. But suddenly when I made the connection between the psychological and the social, actually that gave me a complete framework to try and manage my condition, because it gave me power to try and look at my social situation and work on that. And it gave me the power to look at my psychological situation and access cognitive behavioural therapy. And suddenly I wasn't quite so powerless, because my condition wasn't just in the hands of the clinicians. There were things I could do myself. So I quite often say now when I talk about the biopsychosocial model is that the biology and the medicine is really important. I wouldn't be here if it wasn't for the life-saving drugs and MRI scanners. So the biological and the medical stuff keeps me alive, but it's the psychological and the social work that I've done through self-management that's actually been enabled me to live. And believe me, there's a very big difference to just being alive and actually being able to live. So thank you very much.
Thank you very much, Anya. Do you want to just take the seats at the end? Is that okay? I think that's really, really powerful about how we connect into people's lives. So we talk about treatment and we go visit the GP, we have interventions, but actually this is about people and where they're at. So I want to look to our people's panel. I keep using the patient word and I hate that. To just ask, so who would like to start us off with any reflections on your personal experience, your experience of today, and any reflections that you would like to share? Jill.
I too started out on the expert patient programme. I went as a participant on the programme and then went on to teach. I did the studying for it and got my accreditation. And from doing that, it's actually part of my treatment now. By going out and doing it, it gave me the confidence to go out and do things, to come here today and do things like this. And also, I've got involved in so many other different things through the expert patient programme. And it's my treatment, it's my reason to get up out of bed on the morning. It really does help to have a reason not to stay under the duvet for the day.
Brilliant, thanks, Jill.
Hello, sorry, it's me again. I just want to echo what Jill said, what Anya said, and reflect on what Renata said. I felt very much the same as you. My journey was from patient, not knowing, I just wanted some way to help myself because I'd had so many years of just having to go to clinicians and clinicians in the end rolling their eyes in the back of their head, or not you again. You know, you can see what's going on in their mind, but you've got nowhere else to go. And I kept looking and I kept looking, and I saw something in a GP surgery which said, "Are you sick and tired of being sick and tired?" And that for me was just like the shining light. And I have to be honest, I didn't go to my first. So I went to the first session and then I chickened out when I got to the door and I went back home again. But I did go on week 2 because the tutors were lovely and phoned me up and said, "Oh, you know, don't worry." They saw me, you know. So, and it was the turning point in my life because I didn't have I thought I had got a life, but since getting one back, since attending a self-management programme, I realised how much of a life I didn't have. And exactly what's been said by everybody else, it's not just for physical conditions, it helps you in every way. And we do run courses for people with mental health recovery from mental health issues, or that currently have mental health issues, and they're some of the best feedback we get on courses. Obviously I became a tutor, and I really haven't looked back. I still have my down days. I'm not saying that I'm a perfect self-manager 24/7. I'm not. But I aspire to be, and that's something I could never have done before. But I would like to thank everybody for the opportunity to be part of a panel which actually can express patients' views. This is groundbreaking. It's the first time I've ever been to one of these events where there's been actually more than one patient, and that one patient usually is an afterthought because we've said, hang on a minute, you've got no patients in this conference about patients. So I'd like to thank everybody very much, and also just to say that for all the commissioners and the GPs and everybody out there, that self-management really is worth investing your time and your money into. Thank you.
Brilliant, thanks, Angie. So there's something really strong about the assets that people have, the skills, the experience, the talents that people with long-term conditions have, as well as other people. And how can we harness and use those and build from those instead of looking at people as an empty shell that we've just got to pop a few pills in? Lynn.
I think it's important to recognise that you don't become a self-manager overnight. It takes quite a long time. And, I mean, I think the evidence shows it takes about 7 years from diagnosis to actually becoming an activated, optimal self-manager. And I know, Angie, I do self-manage optimally every day because it's what is important to me and it's how I've done and how I've kind of learned as I'm going along, and I'm still learning. So self-management is really important. It doesn't work for everybody, and it doesn't happen overnight, and it takes time and it takes effort, and it's hard work. And actually, I don't understand my condition, but what I do understand is what my life is like with it, and being a good self-manager means I can manage the impact my condition has on my life. And I have a life. So thank you.
Thanks, Lynn. I'd just like to follow on from that, actually, because I'm paralysed, so without the support of others, I can't even sit up out of bed. I can't do anything. I rely on others to support me through the most basic bodily functions. But I can still self-manage because I'm supported properly. And that just means that I've got one trained person that can support me with everything I want to do. It means I'm not sitting in the house waiting for fragmented care, for district nurses to visit to do some things and for social care workers to support me with others. I just have one person that can support with my life. And with that sort of support, I've travelled the world, I've been to villages in Africa, I've been to America, I've just done everything that everybody else does. It's about getting back to normal. It's not anything complicated, it's just getting back to normal.
Being allowed to live a normal life.
Yes, as a long-term renal patient, I had a somewhat different journey than I think a lot of the members of the panel, because I was diagnosed with kidney failure in 1977 when the options were self-care or go home and die. Really, the options were have a transplant where the outcomes were appallingly poor, or learn to do home dialysis, home hemodialysis. So I'm a pretty good self-manager as far as renal failure is concerned, and I've trained the renal unit where I go to, and we work together very well. However, the culture shock comes as you get older, and all the rest of you starts to crumble away. The kidney's fine, incidentally, it's just the rest of me. Is you go to the hospital clinics, and you find that suddenly you've turned into an idiot. And what's more, you've turned into an idiot with loads and loads of time to wait. And I deeply resent the assumption that we've got all the time of the world, but professional time is really valuable. Now, as a self-employed person, I know exactly how much an hour of my time is worth. And if the NHS could pay me back the hours of time I've wasted, I could retire tomorrow. But I think if I could get one thing from health professionals and everyone else, it would be how to live with the uncertainty of having a long-term condition. I'm not saying that I can't plan to go on holiday, but I don't know how long my kidney's got. So I don't know how I'm going to be able to pay for my retirement. I don't know a lot of things that a lot of people take for granted. And if people could just help us to do that, I think that would make a lot of people's lives a lot easier.
Thank you very much, Sue. So, Jonathan, can I ask you, and then I'd like us to turn our minds to some feedback about some of the sessions that you guys have been in today and your reflections on the patient perspective of what you've heard, and I use the word patient deliberately in that context. Jonathan.
I was just about to do that, so thank you.
Thank you.
I guess I've got a personal plea today, and that is that we stop talking about the system. We stop talking about whole system change. we start talking about the real patient pathway, not the one that we look at when we're in the boardrooms, a multidisciplinary team when we're in management, and we say, let's start talking about what really matters. Yes, keeping us alive is important, but as Anya has said so eloquently already, it's not enough. So let's stop talking about the system. Let's start talking about people. And let's start talking about the time and space in their lives where we can really intervene outside of the hospitals and the GP surgeries. Thank you.
Thank you very much, Jonathan.
Can I make a couple of possibly controversial comments that might upset certain people? Thank God for getting rid of this word, expert patients. I never wanted to be a patient, let alone an expert as it. So whoever did it, thank you very much, because I think it's much more empowering to be someone who can manage themselves. But as from observations today, and contrary to what has just been said, that actually sort of innovation in systems in one of the sessions I attended was actually very inspirational because it was driven by a parent because their child had not been well, and if they hadn't been passionately driven to do something about it, they wouldn't have come out with a very powerful IT system that's been able to empower a lot of people to self-manage and to actually take some power back. But one thing I'd also like to say about today, I've had MS for many, many years now. A lot of those years was undiagnosed. But it's interesting what you pick up when you come to these conferences, and it was actually a clinician that made a very powerful comment at one of these conferences when talking about his own experience, and that was never waste a crisis. I didn't understand it at first, but it actually dawned on me later that was so powerful, because actually we can be positive, we can be self-managed, but I have crises every day in my life, but I've just learned to try to deal with those crises. But I would like to share that with everybody, to use that as much as possible. Never waste a crisis. And if we're open and honest, we're living with these conditions, but we are facing some level of crisis every day. And let's not shy away from that. Let's deal with that head on.
Thank you very much. So there were some people who went to one of the workshops and came back with some feedback about this systems comment and the payment mechanisms and transparency. So if we don't understand how services are paid for and funded, how do we start to change that? Who was it that gave that feedback? Can you? That's okay. Don't apologise. So just talk us through that, Angie, because I think that was a really interesting reflection that perhaps some of the commissioners and policymakers might need to think about.
Yeah, it was about payments and changing ways of payments. But the message that I took away from it was I had to stop everybody and say, sorry, I'm probably the only person in the room that doesn't actually understand the payment system. So I didn't understand, how much XYZ costs. I know some of it now through my work, but I don't know enough to kind of feed back to anybody else. And in my self-management groups, people ask that all the time, and I also think that people would be a lot more careful and a lot more into self-management if they realised, how much every time they tipped up at the A&E is costing, etc., etc. But also, the big message I took away from it was that transparency is absolutely integral in everything that we're doing. because we're talking constantly about patient-centred medicine, about shared decision-making, about patient involvement, and yet there is so much that unless you're privileged enough to have worked with clinicians, have clinicians as friends, sat on some of these panels, been to some of these events, and you pick up little bits and pieces and you start formulating. Surely, and I am going to use the word patient because we all at some point in our lives are patients and we use the NHS. We need to know these things. We need to have the information available because about all kinds of things, because at the moment we put our faith into people and that we're getting the right things done for us, the right things prescribed, etc., etc. And informed treatment decisions are kind of really the way to go forward. But if people aren't transparent about everything from payment systems to medication, etc., we're not going to be able to do that, and we won't move on from where we are now.
Cool, thank you. There was also a point that came out about, and I think it might have been in the mental health parity of esteem conversation, about if you've got budgets that are separate, so you've got mental health over there and you've got physical health over there, and the funding pots don't join up, how on earth do we talk about people? Was anybody in that workshop? No, total silence from everybody. Have I just made that up?
Yeah, I think we're all talking about changing, and everybody in this room is really positive about change. And something I've picked up all the way through the day is the funding structure seems to be embedded there. And to give you a personal example, 3 years after my accident, I had a baby. And I was told that that was a responsibility of children's, and they sent a separate carer in, and the carer that was paid for by children's could do the baby's ironing but not my ironing, and the carer that was paid for by adults had to do my ironing, and it was all so broken up that it couldn't function properly. And I'm sort of getting that impression again today, that everybody's got their budget and it's so broken up that it doesn't all work seamlessly. I think that's the message.
Thanks, Penny. Bonnie.
I think one of the areas that I felt it's been a fantastic conference, and really, really great to hear some of the good positive things that are happening both in engaging patients and integrating care and coordinating, or care coordination, which I think is a really good term. But I would have liked to, or I'm disappointed that there aren't some good case studies involving social care here today. It's quite a health-orientated programme, and this is about integrated care for long-term conditions. And I think we've heard lots of comments about the gap between acute care, community care, and the funding care. And it would have been really nice to have heard some examples or views from social care and community health. But it's been really fantastic. And I would like to say, as a cancer survivor, I feel humbled by the experiences of my colleagues, and I feel a bit of a fraud. But cancer survivorship, or living with and beyond cancer, as it's now called, is now recognised as a long-term condition. And there are 2 million cancer survivors around now, and that figure is increasing. So I and some colleagues are doing a lot of work about recovery packages and rehabilitation, but it's going to have an enormous impact on primary care. So we really need to make sure that that's all happening well.
Cool, thank you ever so much, Bonnie. We'll hear from Joan, and then I want to open it out to questions. Dominic, I might pick on you, just to warn you.
I think the conference so far has been very interesting. And my fear is that we're all going to go away and we're going to pay lip service, and we're not actually going to make changes. Because when you hear about the budget situation, they're now talking about giving people responsibility for their own health budget. But what does that mean? Have we still got to fight the system? Because as a patient, you're given drip-fed information, and it is about I want to be at the centre of my planning. I want to be at the centre of my care planning. I want people to talk to me and not talk at me, because I'm the person that lives with a long-term condition. I've got several long-term conditions, but my consultants don't talk to each other. So why do I have to continuously tell my story? So I think out of it, there's a lot of stuff has to be done around the IT systems and about health and social care talking. It's about the acute trust and the clinical commissioning groups talking. So I think this is the positive side of it is it's a good step forward, but I don't want to have to come to another conference in a year's time and find out, do you know what? Nothing has changed, the system's broke, and the government's going to change it anyway. It's about, we've got to take responsibility, and it's about listening, because at the end of the day, everybody in this room at some stage will become a patient.
Thank you very much. So, any reflections from people in the audience out there, or any questions you'd like to ask? I wondered if Alison was here and wanted to make any mention of personal health budgets, but I can't spot her. She's run away. Okay, gentleman at the front and then gentleman just behind.
Thank you. Can you hear me?
Yeah.
Okay. I don't want to talk too much about Self-Management UK because our Chief Executive has just done that wonderfully well. I did want to come here today and not miss the opportunity to ask a few questions and get some answers. And fortunately, Angie Usher and one or two other people on the panel have done that marvellously on everybody's behalf, I think, which is great. But I do want to make a couple of comments, I think, more than anything, which is we've all heard today from people on the panel with a variety of long-term conditions. And I myself joined Self-Management UK with a long-term condition when I was diagnosed with cancer some years ago. And I wanted to make the point that from my perspective as a hard-nosed businessman, if you like, before I joined Self-Management UK, was when you get diagnosed with a long-term condition, it does change your life. And one of the areas that we're particularly involved in and want to get more involved in is getting more and more people through our courses and helping them to cope with long-term conditions. And it strikes me today, we've had a cross-section of people here that have got a variety of long-term conditions and spoke eloquently about what we need to do and so on. I can remember going to the launch of a program that we did for the young people. And it strikes me that for me to be reduced to tears, and I was, when I listened to young children with a number of long-term conditions, having to live with those conditions for the rest of their life, that we've got to get more done and not just talk about it. And I heard Martin McShane earlier on at the beginning of the conference talk about what we're going to do, what pledges we're going to make. And I'm sure my Chief Executive will be delighted to know that I've made a couple of pledges already and left them on the board of things that I've seen and things that I think we can improve on. But I'd like to make a challenge to Martin that he's got to go away from here today and understand the passion and the benefits of self-management to the NHS and to help us make it happen.
Thank you very much. I won't go to Martin to respond because Martin's going to close the session, but I know he will respond to that. Can we just go to the gentleman here? Thank you.
I'd like to make a reflection to some of the fears expressed by the people that is this all going to be lip service.
Sorry, could you talk up a little bit? Speak right into it.
I like to make a reflection in response to the fears of some people that it's all going to be a lip service. I'm an acute medicine registrar. I'm training. I see people who come through A&E every day, and I can assure you there are a lot of healthcare professionals who are really frustrated without knowing how to help people with chronic conditions who are, usually very wrongly called by healthcare professionals as revolving door patients or expert patients because they come to A&E because they don't get the help. I'm very grateful for everybody's sharing of this experience, and I'm sure next time I see a patient with emphysema who's come to A&E for the 30 times, I would probably log into the internet and find an appropriate self-management program and probably try and refer the patient. So I'm sure this is a good success.
That's fantastic. Thank you. I think there's a massively important message in what you've just said about the information available to health professionals about where you can send people. And I think we all really need to think about that very, very clearly. Alf.
Alf Collins, I work in the Health Foundation. Incredibly important that we support people to enter self-management programs. Just as important that when they come back into the health service, they are continuously enabled, and we should make every single contact count so that every time people who are self-managing see a health or social care professional, at the end of that visit, they are more enabled, not more disabled, which clearly can very often be the case. I think we need quite a large workforce development program to support the workforce to develop some of the skills that can make that happen.
Thank you very much, Alf. I'm going to run over here.
I'm not sure I ought to be doing this, but we heard this morning from Jonathan what matters, and we heard from Ed Wagner how to do it. And I've got a question for the patient panel.
People's panel.
The
People's panel.
People's panel. The People's panel. It is possible now, it's perfectly possible to get a care plan together which involves all the different agencies for a year in the life of social services, community, voluntary sector. It is possible to cost that using data which is obtainable within the National Health Service. It's therefore possible to fund it to an agency, be it general practice or whatever else, to provide that care, so that everybody with a chronic illness, a long-term condition, ought to be able to have the care they need provided in that way, personalised. Now, I'm a paediatrician, and I'm used to the notion of statements and so forth. So if we were able to achieve that, we can't do it tomorrow, but would that be helpful if everybody had a care plan and the means of delivering it from multiple agencies and the key worker to act as the agency to do that, which is what Ed Wagner said? Would that be helpful? And if we did it, if it would, why don't we do it?
Thank you. You certainly can. I can't run anymore. I should never have worn heels. I should take my shoes off.
I could give a personal example here because I tried to organise a care plan myself with my GP and my MS nurse and me, and I was the one who organised it, and I was the one who was trying to do it because it's not happening. Care planning is not happening. It might be, we might be saying it is, but it's not. Unfortunately, the meeting didn't happen because the MS nurse had a crisis the night before, and so I ended up at my GP's, and we couldn't do it. We could not make a care plan, me and the GP, because we needed the MS nurse there, because he knows what I need, the GP knows what's available, and I know whether or not I'm going to do it. So you need all three of us, and it's not happening.
Cool. If you look at our participation guidance that we published last week, there are commitments in there, and there's a lot of information about personalised care planning. There's links back to the National Voices website. We have to make that happen, but how do we make it happen when it's not happening? Because we can write the words and say everybody with a long-term condition or a disability should have a personalised care plan by 2015 or whatever it says. But as Lynn says, how do we actually make it happen?
Hi, my name's Sharon. I'm a cardiac specialist nurse from background, and I've recently gone into commissioning. And my role at the moment is to, I'm a locality development manager. I'm also trying to look at cardiovascular disease and kind of trying to bring things together instead of having kind of separate conditions, bringing it together as one family of diseases so that we can kind of try and pull in those services and make it easy to get those care plans more robust and people thinking a little bit wider and outside of the box. I come up against challenges every day, and certainly what I'm finding is the politics behind it within the NHS and the way that services are commissioned and funded, and the way that service specifications are developed behind these services, because the providers are very much, this is a business. I'm running a business here, so I can only do this, and this, what is on my service specification, because anything outside of that, you're getting for free. So it's really, really difficult trying to crack that mentality of, yes, it's a business, but it's a business which involves people and people's lives, and it's all right to step outside of the box. And so what if we do something that's free? But everything in the NHS has got a tariff and a cost attached to it, which makes it so difficult to kind of get providers thinking in this way. It's very, very difficult and frustrating. And I think to get where we want to get to with what everyone said today, we just need to keep chipping away and changing people's mindsets and getting people thinking outside of the box.
Thank you very much. I think that goes back, I'm going to come back to you in a minute, Renata. It goes back to that, how do the funding systems work as well? So if it's on tariff, how do we change tariff?
Hi there, my name's Sue Elvin and I'm a nurse consultant for district nursing. There's only actually 2 of us, one in England and one in Scotland. Fortunately, I only cover Camden. And I just wanted to talk about a dirty word called resourcing. And that actually, I'm very committed to enabling patients to self-care. But actually, we've piloting a brilliant program, I think, enabling patients to self-medicate. But it actually takes a very long time to support a patient to properly assess their needs. That takes a minimum of an hour in the patient's home. And then to work with that, person, patient, whatever. I've been around for a very long time. Patient's been in my head for over 30 years. It's difficult to move on. And then to do the follow-up program with that patient. And just to give you an idea, the average nurse, district nurse, and there's only 6,000 of us left in the country now, qualified, which is important. We're seeing between 12 and 19 patients a day. We need resources.
Thank you. Point really well made. Okay, I'm being told to wrap up now because we're going to run over. But I do want to ask Alison, because she had her hands up, and then I want Dominic to have the closing word, if that's okay.
Hello, I'm Alison. I think one of my labels is heart sink patient. I heard that. I think I'm a frequent flyer, at least 100 admissions to hospital. I stopped counting then. So that's why I'm here, really. I'm also now a fellow of a applied health research program. Self-management, well, it was only when I started to manage my own condition and get some of the real power back that I stopped being admitted to hospital. It's not rocket science, that's what worked for me. But I'd like to see it taken much, much further, because someone that's been at least 100 times in hospital observes a lot, and that is expertise that can actually be used to change the services. So not just to manage our conditions in isolation, but use that experience to work in partnership with professionals, not just having our experience captured. I've got consultation fatigue as well. I don't want my experience captured anymore. I want to remain part of the process, and I want to be part of redesigning the projects. Now, just to get that point across, I am currently doing a co-design project, which I've defined on my old psychiatric unit. It's called Lunatic Takes Over Asylum. So yes, the system is a necessary evil, but it can be changed. In Sweden, in Jönköping, one young man having dialysis who was from an engineering background. I don't know if Jørgen Henriks from Kulturum in Jönköping is here yet, but this is from his patch. He just asked the nurse doing the dialysis, can't you teach me to do that myself? Now, something about whether it was the nurse or the culture there, whatever, it led to complete redesign of that whole way of managing. I mean, complete redesign by patients in partnership with professionals, in equal partnership. And it's really inspiring, and that's the sort of thing we need more of. Not just managing our own conditions, but using us as partners, right, and to be partners in that. So this for me has been the most real session of the whole conference so far. So thank you very, very much.
Thank you, Alison. Dominic, you drove yourself quite a long way and across quite a few mountains. So last word to you.
I've come to a very big conclusion. I have to say, listening to everybody talk, including the nurse over there as well, I've took a few notes down of what people have said. Getting back to normal, my time is worth as much as professionals. I don't know when my kidneys will pack up. My time is important. And I think what a lot of it really comes down to is self-worth. And that's one thing I've been struggling with lately. I haven't felt valued. I am starting to feel valued. But tokenistic engagement is worse than no engagement. And speaking from a mental health and long-term condition, get all my words right, you can tell I'm a bit new, I've got to earn my stripes. It really comes down to valuing people as people. We're not patients, like the gentleman said. We're people, and we need to be valued and seen as that. And I think the people making the decisions, we've got to be there with you guys doing these decisions. You need to see us and never forget who you're dealing with and value us, because we have value.
Thank you very much, Dominic. Thank you very much, our people panel.